Hello everyone, I'm Arjun Thiyagarajan, postgraduate resident in Kolkata Institute of Medical Science. So my paper is about imaging manifestations of posterior reversible encephalopathy syndrome on MRI. The aim of the study is to identify various imaging manifestations of PRES on MRI. It is a retrospective study analyzing a radiology report and MRI images of 46 patients with a clinical and radiological diagnosis of PRES. The MRI images obtained were T1, T2, flare and diffusion sequences. The location of the abnormal signal intensity as well as the presence or absence of atypical features such as diffusion restriction and hemorrhage were also recorded. The results were number of cases of 46, out of which 4 were males and 42 were females. The age range of the populations varied from 10 to 75 years of age. The most of the patients were in the age group of 21 to 30 years, followed by 41 to 50 years, which were accounting up to 21%, and the 50 to 75 years, which were accounting to 17%. There are 2 cases in the age group 10 to 20 and in the age group 41 to 50 years. The presenting complaints are variable. Majority of the patients in a study presented with peripartum or postpartum eclampsia. The children in the age group of 10 to 20 years are high blood pressure due to secondary to glomerulonephritis. 10 adult patients presented with epilepsy and 6 other patients with non-specific complaints such as headache and blurring of vision. The most common involved locations were found to be parieto-occipital lobes in almost all the patients. This was followed by the frontal lobes, which were in 14 patients, cerebellum in 8 patients, in temporal lobes in 4 patients. The other atypical regions involved were basic ganglia in 10 patients, the brainstem in 4 patients, and then in thalamus in 20 patients. The imaging features consisted of bilateral symmetrical parieto-occipital white matter hyperintensities. Some cases showed atypical features such as hemorrhage and restricted diffusion. The hemorrhage was seen in 9% of the cases. Diffusion restriction was seen in 57% of the cases on DWI, which doesn't correspond to the ADC values, so that shows it's a pseudo-normalization. Follow-up imaging of 4 patients showed disappearance of restriction in 24 hours. We start the discussion now. The PRES is a neurotoxic syndrome occurring due to the susceptibility of posterior circulation to variations in blood pressure. When the BP variations are sudden, the posterior circulation is unable to maintain the perfusion of the posterior, the structure it supplies. It is classically characterized by a symmetrical parieto-occipital white matter edema. The imaging manifestation may vary and can include atypical locations and hemorrhages. The posterior circulation has a relatively sparser sympathetic innervation than the carotid circulation. The cerebral blood flow is regulated by dilation and constriction, which maintains adequate perfusion at all times. A rapid rise in blood pressure overwhelms the normal autoregulative mechanism, which leads to dilatation and subsequent leakage of cerebral arterioles, which results in the vasogenic edema. The threshold of this breakdown of autoregulative mechanism were found to be around 170 to 190. Even though this theory proposes cerebral hyperperfusion, few studies have shown that actually there are hypoperfusion that induce PRES. There's one more theory which is discarded because of it emphasizes on endothelial dysfunction as a result of systematic inflammatory responses causing as a cause of PRES. This theory is supported by the common association between PRES, systematic inflammatory condition such as sepsis, preeclampsia, post-transplantation, autoimmune diseases. But PRES can occur in conditions apart from this. So this theory has been discarded. The most imaging features are most commonly T1, hypo, T2, flare, symmetrical hyperintensities on MRI on parieto-occipital lobes of both hemispheres. Similar areas of altered signal intensity can also be found in other locations such as the frontal lobes, cerebellum, brainstem, and basal ganglia, which can include the atypical PRES. The central variant of PRES, which has an isolated involvement of the basal ganglia and brainstem with no involvement of the subcortical white matter, was seen in 4% of the cases in study by McKinney et al. But in our study, the basal ganglia was involved in around 22% of the patients, brainstem in 9%, and thalamus in 4% respectively. However, all these cases are changes also in the typical location along with the central variants. The first image is a T2 image, and second image is a T2 flare, third image is a DWI. The T2, all these sequences shows a symmetrical hyperintensities along the parieto-occipital lobes, which in DW you can appreciate a certain diffusion restriction mainly contained within the posterior circulation and the territories. This is one another apical location in which there is T2 hyper and then T2 flare hyper intensities in the right lobe of cerebellum. Diffusion and upper and ADC have been found to helpful in differentiating between atypical presentation of PRES and other conditions which induce symmetrical hyperintensity such as extrapontine central myelinosis, non-hemorrhagic infarcts, hypoglycemic hypoxic encephalopathy. Due to the edema, there's ADC shows increased value with slightly increased signal on DWI, whereas other conditions will show true diffusion restriction. That is DWI. There is restriction with reduced ADC values. That's how we differentiate between cytotoxics and vasogenic edema. Vasogenic edema occurs in PRES, so there will be a mismatch of the diffusion. The severity can be divided based on the involvement of cortical, where if the cortical white matter edema without parenchymal hemorrhage, mass effect, or any one of the following structures, including the cerebellum, brainstem, and ganglia, any one with this edema which comprises mild PRES, confluent edema extending from the cortex but sparing the periventricular margins, or mild involvement of the above mentioned two structures, which is cerebellum, brainstem, basal ganglia, will contain moderate PRES. The severe PRES is extending from the cortex to the ventricle with midline shift or herniation, or involving all the three structures of the cerebellum, brainstem, and basal ganglia is categorized under severe PRES. So differential diagnosis are cerebral infarction, cerebral venous thrombosis with demyelinating disorders, metabolic disorder, and encephalitis. Treatment is adequate control of the hypertension and removal of the offending agent. Most patients recover within 24 hours. Then the vasogenic edema may progress to cytokine edema if not controlled. The conclusion is the involvement of the parieto-occipital, frontal, and temporal lobes is common in PRES. Occasionally, there may be involvement of basal ganglia, cerebellum, and brainstem. So these are my references. Thank you.